Welcome back. This is Mark Purdue, and you're watching EKG video tutorial section 7.0 on ST segment and T-wave analysis. Following our raised right mnemonic, we have gone through rate and rhythm, identified axis, we have looked at the intervals as well as indicators of increased chamber size, and now we are on to ST and T-wave evaluation as well as other indicators of infarction. Before we dive into the ST segments and T-waves, I think it'll be worthwhile for us to review the anatomy of the coronary arteries. Recall that the right coronary and left coronary arteries arise directly off of the aorta. In fact, they are the first arteries to come off of the aorta. Here you can see where the right coronary artery emerges from the right aortic sinus. Here you can see where the right coronary artery emerges off of the right aortic sinus, and the left coronary artery comes off of the left aortic sinus. During systole, blood will flow across the aortic valve and into the aortic arch where it enters into the systemic circulation. As a result of elastic recoil on the aorta, blood will be pushed back toward the valves, causing it to snap shut in diastole. Consequently, blood will fill the coronary sinuses, and while the heart is relaxed in diastole, this same blood will flow into the coronary arteries and provide perfusion for the heart itself. After the coronary arteries emerge from the aorta, they run superficially on the heart and are largely ensconced in fat until they dive deep into the muscle to provide perfusion. The right coronary artery comes out of that right coronary sinus, and then it runs anterior to the right atrium and then courses laterally where it gives off a right marginal branch that is on the border of the right ventricle. The RCA then courses posteriorly, and in many patients it gives off the posterior interventricular branch. On the left side, we have the left main coronary artery, sometimes just called the left coronary artery, and as it dives into the coronary sulcus and the interventricular groove, it is going to give off the left circumflex branch, which is going to run laterally and provide perfusion to the left lateral wall of the ventricle. Here we can see the left anterior descending, sometimes called the anterior interventricular artery, is going to come down on the anterior wall and provide perfusion for that anterior wall of the left ventricle, as well as wrapping down into the apex. If you look to the left, we can see kind of a sagittal section of the coronary arteries. Here again, we have the left coronary artery, sometimes called the left main, and then it's going to divide into the LAD and into the circumflex, which has been cut away for perspective. The anterior branch, or the LAD, is going to come down to the anterior wall and then provide perforating arteries that are going to perfuse the anterior wall, as well as septal branches, so that the anterior 2/3 of the interventricular septum will be perfused by the LAD, or left anterior descending artery. On the posterior wall of the heart, we have this posterior interventricular branch of the RCA that comes off. On the posterior wall, we have a branch off of the right coronary artery called the posterior interventricular branch, which is going to send perforating arteries that will perfuse the posterior 1/3 of the interventricular septum. There's a fair amount of variability in coronary artery anatomy. One important theme is the so-called dominance, which refers to which side of the heart, right or left, will give rise to the posterior interventricular branch. In most patients, around 67%, according to Moore's clinically oriented anatomy, the RCA will give rise to the posterior interventricular branch, as seen here. When that happens, there is a more or less balanced from the left and right system, again with the anterior 2/3 being picked up by the LAD, the posterior 1/3 of the septum, and then the right ventricular wall and posterior wall being picked up by the RCA. In a smaller percentage of the population, something like this might occur where the circumflex gives off the posterior interventricular branch. Here you can see in a patient with this type of anatomy, there will be a disproportionate amount of the heart that is perfused from the left-sided systems, so that left-sided problems like a left main lesion is going to be a big problem. Even more worrisome still is going to be a patient with a sole coronary artery, so that the entire amount of blood flow is coming from one vessel. We can also see a variation like this in which the right coronary artery actually gives rise to the circumflex as it wraps around to the left side of the heart, so that there is an unbalanced amount of right-sided perfusion to the entire side of the heart. It will also be useful for us to review some terminology associated with acute coronary syndromes, ischemia, infarction, and necrosis. The internal lining of the heart, or the endocardium, actually receives nutrients and oxygenation from direct diffusion from blood that is actually inside of the ventricle itself. The rest of the heart is going to be perfused by the coronary arteries in the form of direct vessel perfusion. As these coronary arteries run on the surface of the heart and ensconced with fat, they will send perforating branches down into the heart so that the first thing that's going to get perfused is going to be the subendocardium, or that first layer of the heart. Consequently, if we have ischemia or infarction, it will first affect the subendocardium, and if it goes on to affect the full thickness of the heart or full thickness ischemia. In terms of electrocardiography, we can see here that in the normal perfused heart, we have a QRS complex and then a T wave. In the case of ischemia, if any EKG changes are present, they are likely to be something along the lines of ST segment depression and or T wave inversion. If that reduction of blood flow is severe enough, then it can reduce blood flow to the entire full thickness of the heart, which is going to manifest with ST segment elevation. If that reduction in arterial blood flow to the heart produces infarction and nothing is done to intervene on it, it will progress to necrosis, which is irreversible damage of the heart muscle, and sometimes that can be associated with changes in the electrical axis of the QRS. If I can direct your attention to the left side of the graphic, you can see on the left-hand side we have what are called transmural infarcts. These are short axis sections of the heart, cut the top of the heart off, and then be looking from cranial to caudal perspective, so that here we have the anterior surface and here is the posterior surface. In this graphic, we can see that a permanent occlusion of the left anterior descending branch is going to produce transmural infarct. That's full thickness. In fact, the word transmural means all the way through the wall. And this infarct, in time, if it persists, will turn into necrosis. Consequently, a permanent occlusion of the left circumflex, of course, is going to gork out that left ventricular wall, and then an occlusion of the RCA will likely produce, and then an occlusion of the right coronary artery that comes around to the back of the wall could produce a posterior wall, and then a little bit of that ventricular septum infarction. Now, let's back up to here again, and we have a transmural infarction. This will present as an ST segment elevation MI. If the patient presents before necrosis has taken hold, we can give them therapies like percutaneous coronary intervention or thrombolysis, which will open that artery up, and then we'll only have some subendocardial infarction without extension into the epicardial layers. That is, of course, the whole idea in the treatment of ST segment elevation MI. With all of that in mind, let's make some clinical correlations in terms of our ACS terminology. Ischemia in the form of stable angina would be signs and symptoms of acutely decreased coronary arterial blood flow that is not accompanied with diagnostic ST segment elevations or an elevation of cardiac enzymes, by which we mean troponin. Stable angina is something that we will diagnose in a patient with known coronary artery disease. Maybe a guy's had several stents or bypass or whatever, and they have a significant stenosis, but they're not a good candidate for intervention or surgery, and so this stable pattern of coronary artery disease can be medically managed. By stable, we mean they get the same type of symptom with the same amount of workload. We can have a patient that's 83, known history of coronary disease, and he gets a little chest discomfort when he walks more than 3 blocks. The patient simply rests and it resolves, and it has not progressed from this point. Ischemia in the form of unstable angina is more severe. Here we have signs and symptoms of acutely decreased coronary arterial blood flow, not accompanied by ST segment elevations or cardiac enzymes, and unstable angina can kind of come in a variety of presentations. One of them is going to be a patient that is new, a 66-year-old male who is diabetic and is a smoker and has family history. He is complaining of chest pain with very low levels of activity, and then he's got these kind of ST segment depressions or some dynamic EKG changes. The question with that patient in terms of the stability of angina is whether or not it's going to be safe to put him through a stress test or whether he needs to go straight to the cath lab. So if you have a patient with no known history of coronary disease, symptoms at rest or with minimal levels of workload, and then particularly if they've got significant risk factors and dynamic EKG changes, you're probably better off consulting cardiology than proceeding with the stress test in those scenarios. Another form of unstable angina will be the so-called crescendo angina. If we take our previous patient, the 83-year-old with known coronary disease, now he's starting to get get pain when he walks from the fridge to the front room or just out to the mailbox. That is crescendo angina. So that would make it in the unstable category. And so the issue with that patient is whether or not these symptoms are significant enough to impair his daily quality of life, which most likely they do. Lastly, it is sometimes said that resting angina greater than 20 minutes in duration should be a criterion for unstable angina, and to me this makes no sense whatsoever. If you're an adult with risk factors and no history of coronary disease and you start getting terrible chest pain, then you should just call 911. If you have a history of coronary artery disease, you're going to take nitroglycerin times 3 over a 15-minute period, and if you still have pain, you should call 911. Whether it's a patient with known history of coronary artery disease or a new patient, sometimes unstable angina on the more severe of this spectrum is going to be something like this. The patient had an unstable plaque, that plaque has ruptured, and instead of going on and producing complete infarction, that clot is waxing and waning as a result of the body's intrinsic clotting mechanisms or as a result of the aspirin or Plavix or whatever. Something is keeping that clot at bay sufficiently that the patient is not infarcting, but the patient is demonstrating symptoms at rest or with very limited levels of activity. Again, this is a kind of patient that you don't want to put in. Again, this is a kind of patient, because of the unstable angina, is best evaluated in the hospital setting, quite possibly with consultation of cardiology. Next is going to be that subendocardial infarction, which clinically we will refer to as a non-STEMI. Here we will have signs and symptoms of acutely decreased coronary arterial blood flow that are accompanied by an elevation in cardiac enzymes, as attested to this elevated troponin level, but not diagnostic ST segment elevations on EKG. This patient comes in with chest pain. Their EKG could be normal, or it could show some ST segment depressions or T-wave inversions, just like the EKG shown here, but the main thing is that they have elevated their troponin. This is typical of a subendocardial infarction where that initial layer of the heart has been damaged by decreased blood flow. Lastly, we have the transmural or full thickness infarction, which is in fact clinically an ST elevation MI. Here we have signs and symptoms of acutely obstructed arterial blood flow that are accompanied by diagnostic ST segment elevations, shown here, and then eventually elevation in cardiac enzymes in the form of a troponin. You do not need initially a troponin elevation to diagnose a STEMI. Instead it's diagnosed clinically with a 12-lead EKG matching these patterns. From a pathophysiologic standpoint, you can see that a vulnerable plaque has ruptured, and this has precipitated complete thrombosis of whichever coronary artery is involved. If that transmural myocardial infarction or STEMI persists and is not treated, then it will evolve into necrosis, and this will be a completed transmural myocardial infarction. On the left-hand side, you can see the evolution of an EKG in a patient that suffered an ST elevation MI in 1970 before the advent and widespread use of thrombolytics and PCI. Here you can see in panel A, there's massive amounts of ST segment elevation in the anterior portion, and then it persists again to form a Q wave, and then we have an alteration of the electrical axis and inversion of the T wave. So you do not have to have Q waves in order to have a full completed transmural MI, but sometimes we do see Q waves as a result of an untreated full thickness MI. Over here you can see this area of pallor as a result of the completed transmural infarction. The patient also experienced a little bit of free wall rupture resulting in bleeding, and the small arrowhead here is indicating an area of previous infarction with subsequent scarring. Next up is 7.1, in which we will focus on ST segment elevations that are associated with myocardial infarctions.